So today we're going to talk about an arrhythmia, and we'll take a look at our 2-lead strip. And in order to figure out what this is, we're going to use our 5-step method in order to find out what this is. Now, taking a look at our rate, we know that we have an atrial rate of approximately 80 beats per minute, while we have a ventricular rate of 30 beats per minute. Our second step in figuring this out is looking at our rhythm, where we have an irregular atrial rhythm, but we do have a regular ventricular rhythm. And then moving on to our third step is to look at our P waves, where we see all our P waves are all upright, but not every P wave is followed by a QRS complex. And then now to our fourth step is our PR interval. So since we have a desynchronization between the P waves and our QRS complexes, it means that we actually do not have a discernible PR interval, which means this is negligible. And moving on to our QRS complexes, we can see that all of our complexes are upright, and they are less than 0.12 milliseconds, also meaning that they're less than 1 to 2 small boxes. So with all this said, we know that we have a third-degree AV block, which means we have independent atrial and ventricular electrical activity. So taking a look at the heart, and drawing an arrow here, this is a representation of the regular electrical activity, which starts at the sinoatrial node, or SA node, and it moves downwards towards the ventricles. And as that moves down, you can see it spread out, which ends at the Purkinje fibers, and the cycle will continue until we die or something goes wrong with this system. Taking a look at our heart again. Now, the junction between the atria and ventricles can be completely blocked off in the case of a third-degree block, which we will represent with this block here. Now, the conduction defects are usually the result of fibrosis of the conduction system, medications, electrolyte imbalances, myocardial infarction, inflammatory disease, or cardiac surgery. Now, as a result of the blockage, the atria will continue to beat as normal, while, like this, while the ventricles will beat at their own pace, which we will represent by here. Now we'll take a closer look at the blockage occurring at our junction. So normally there's a straight pathway for which the conduction occurs, and this is what we see in healthy hearts as conduction moves from the top to the bottom of our hearts, which we'll represent with this arrow here, straight pathway. Now taking a look at our junction again, and we will draw this block here representing an occlusion. So as fibrosis of the heart, hypertrophy, myocardial infarction, or inflammation sets in, the conduction pathway is partially blocked, and normal impulse can no longer reach the same destination, which creates a different pathway at a slower conduction speed. And this will be our secondary pathway, which is slower. Now here we'll draw a larger block. So the progression of the blockage creates more and more accessory pathways until there's no more room for any pathways to reach the ventricles. Now this causes entopic foci in the ventricles to become the pacemakers and create their own rhythm, while the atria continues with the AV and the SA nodes. And this is represented by this arrow here, where our conduction cannot go through. So looking back at our 2-lead ECG, or lead 2, we can see that the atria represented by the P waves are firing independently of the ventricles at their own intrinsic rate of approximately 60 to 100 beats per minute. And this conduction is coming from our SA node. While the QRSs are representing the ventricular pacemakers, which are firing at their own intrinsic rate of 20 to 40 beats per minute. Now this leads to our pathological consequence. So the pathophysiological effects of this rhythm is due to the faster atrial rate and the slower ventricular rate, we have an increase in preload and a decrease in our ejection fraction. So because of the ventricles unable to pump blood out of a heart fast enough, this builds pressure up inside of the atria. And this results ultimately in the congestion of the pulmonary circuit and venous system, which leads to congestive heart failure when the heart decompensates.